tonight's PULM webinar. We've got three great speakers, Kemble Wang, who's one of my colleagues from the Children's Hospital in Melbourne, and we're also very fortunate to have Kristen Davidge and Petra Grahn, who are both going to speak to us after Kemble. Could I ask everybody who's not speaking to mute themselves just to reduce the background noise? And please put your questions in the chat so that we can have a discussion at the end of the talk, because that's where a lot of the value of this obviously is. So thanks very much. And Kemble, who I'll introduce, he's an orthopaedic surgeon, works in the orthopaedic department. I work closely with Kemble both in our congenital clinic as well as our plexus clinic, and he's a very smart guy and a good thinker, and I appreciate Kemble putting together this talk for us on Salter-Harris type 3 and 4 fractures of the radial head in the pediatric population. So thanks Kemble.
Thanks, Dave. Thanks, everybody. So I'd like to thank the other contributors to this talk, including a couple of our previous fellows, as well as Eugene Eck. So we're talking here on a specific subtype of radial head fractures, one we may have encountered, and I find a very difficult group. So we're talking about Salter-Harris 3 or 4, where the fracture line goes into the joint, not a Salter-Harris 1 or 2, which is the typical what we call radial head or radial neck fractures. And we're not talking about an intra-articular radial head fracture in the skeletally mature. Those are very different things and do not behave like the one on the left, which is Salter-Harris 3 and 4 fractures. The other ones have their own challenges, but nowhere near, I think, the challenges that we face with the Salter-Harris 3 and 4 fractures, which are rarer as well. Just to go through some of the natural history. So sometimes when I first encountered these, I always found it a bit scary how unexpected and quickly they go from looking benign to looking like this day 7, to looking like this at 3 months down the road, to looking like this at 6 months down the road, with gradual subluxation, destruction of the radiocapitellar joint, synovitis, stiffness, very rapid onset despite. So that's the natural history. Here's another example at day 12, a very similar minor looking radial head fracture. This is it at 6 weeks of fusion, and this is it at 8 months down the road with destruction of the radiocapitellar joint and subluxation of the joint. Here's another one, picked up relatively late at 4 months down the road. Here it is at 1 year with destruction of the radial head, and here it is at 4 years down the road with degenerative changes and bone-on-bone changes to the joint. Here's another one at day 0, minimally displaced radial head fracture with a CT there showing pretty undisplaced, but here it is at several months down the road with destruction of the radiocapitellar joint. Not only does this injury seem to affect the radiocapitellar articulation, but it seems to very rapidly start to involve the ulnohumeral joint in a number of cases. So you can see here 6 months down the road with no intervention, the natural history shows that it starts to affect the ulnohumeral joint with cystic changes there and destruction of the joint in the ulnohumeral space. Here's another one. The initial fracture looks so minor, just that top corner here. And here it is at 6 weeks down the road. And here it is at 9 months down the road with large cystic changes in the ulnohumeral joint. And here it is at 18 months down the road with severe destruction of both the ulnohumeral joint as well as the radiocapitellar joint. You can see here that the radiocapitellar joint has also flattened on the capitellum. So that's some natural history of this injury. Why do they behave so badly? Our thoughts are is that it's primarily an AVN-driven process, similar perhaps to what we see in subcapital femoral epiphysis injuries in the pediatric population, or potentially some intercondylar phalangeal fractures. There is disruption of when this injury occurs, there's disruption of the perichondrial vessels, there's disruption of the transverse epiphyseal vessels, and the open physis, it seems to be a barrier to rapid revascularization, which may be why we don't see this in adults, but we see this when the open growth plate is still present. And perhaps when AVN sets in, there's an inflammatory immune response, which perhaps is the best explanation for rapid involvement of the ulnohumeral humeral joint, as the radial head is really an end organ with limited blood supply. So every time I give a talk on this topic, people invariably say, oh, surely don't you think this is primarily a lateral ligament phenomenon, and it's a stability phenomenon causing degenerative changes? And my response to that would be that I think the lateral ligament and subluxation issue is a secondary phenomenon, not a primary phenomenon, because you see this injury with a central fracture pattern without subluxation, as you can see on the bottom left-hand corner, and it also has the same natural history. And you see this injury with anterior subluxation of the radial head, as in the bottom right-hand corner, and it still has the same poor natural history. So a lateral ligament phenomenon doesn't explain the rapidity of the ulnohumeral joint destruction either, or destruction in undislocated cases and anteriorly subluxated cases. So previously, this injury is recognized in literature as a bad behavior, a bad sort of injury with bad outcomes. Chuck Goldfarb, Don Bates group published on this with N equals 7 patients, showing that this is a potentially rapidly badly behaving fracture, as well as other groups that have published saying it's a deceptive type of injury. So our aim is to look at all the cases that we've dealt with and to try to define the natural history as well as treatment outcomes of the skeletally immature elbows with these Salter-Harris 3 and 4 radial head fractures. The methods was a retrospective review of all Salter-Harris 3 and 4 radial head fractures at our center over about a 5-year period with minimum 12 months follow-up. And so we identified 20 patients, 16 were boys, 4 were girls, and the mean age at time of injury was 11 years, with a range between 6 and 15 years. 25% we think are Salter-Harris 3. Sometimes it can be a little bit difficult to differentiate between the Salter-Harris 3s and 4s, but most I think were Salter-Harris 4s. 80% were treated with some form of open reduction internal fixation, and 4 patients were never treated with internal fixation. If you look at the results, the overall avascular necrosis rate of the radial head was around 60%. The overall radiocapitellar joint subluxation rate was 65%. The overall radiocapitellar joint degenerative changes were seen at later follow-up in half of patients. In 4 patients, they went on to requiring radial head excision, and in 10% of patients, 2 of them had underwent radial head replacement. If we broke down this group into 3 subgroups based on whether they had early internal fixation, i.e. fixation at less than 2 weeks of the injury, versus late internal fixation done after 2 weeks of the injury, versus no internal fixation, we have approximately this breakdown with 50% of patients in late fixation group, because they're often picked up late. They initially may be missed or thought to be quite benign. So a large number are in the late fixation group. If we look at the early fixation group, now there were 6 patients in this group. These patients were picked up and identified and are treated with internal fixation at less than 2 weeks of injury. And what we find is that 5 out of the 6 patients united. Only one out of the 6 patients had undergone AVN, and none had radiocapitellar joint degenerative changes. If we identify those that had fixation late at greater than 2 weeks down the road, of which there were 10 of these, with a mean time to internal fixation of about 18 weeks and with a range of 3 to 60 weeks down the road, 40%, only 40% of these united. 70% of them had undergone avascular necrosis at latest follow-up, and 60% of them have radiocapitellar joint degenerative changes, with 80% having radiocapitellar joint subluxation. And if we looked at those 4 patients who never had internal fixation, then we see that 100% of them underwent avascular necrosis, radiocapitellar joint degenerative changes, and all were symptomatic at latest follow-up. So if we compare these groups in a table format with early fixation, late fixation, or no fixation, we see that union rate is progressively poorer, comparing early to late to no fixation. AVN rate is higher, comparing early to late to no fixation, with no fixation having the greatest risk of AVN, and degenerative changes also behaving in the same way. So early fixation appear to do better than late fixation, which once again appear to do slightly better than having no fixation at all. So what have we learned from fixing these in the late group? Because often you pick these up at 3 weeks or more down the road when they haven't done well or are showing more signs, and MRI showing subluxation with non-union. What have we learned? Well, this approach has sort of evolved over the last 8 years, and I think I've made every mistake there is to make looking back. So firstly, I think soft tissue handling is important. So the periosteum that is still intact, or some parts of it that may still be intact, it's very tempting to go through that periosteum to try to elevate the piece and fix it back, but that's probably the only last bit of blood supply left to that part of the radial head. So we approach from inside the radial head to preserve that radial head. I've been ablating the physis if they're greater than 10 years of age to try to remove that barrier to revascularization. And I've been going to headed screws, not headless screws, for radial head fixation, which may seem very counterintuitive, and I'll go into details of why for that later. What hasn't worked for me in the past is that when avascular necrosis has set in, any contracture release in this group just does not work. We do contracture releases of the elbow for many conditions, but this is one group that's extremely resistant, and it does not work when AVN has set in. Lateral ligament reconstruction, if we think that the lateral ligament stretched out, the radial head subluxate, that's a secondary problem. Reconstructing the lateral ligament, once again, have been met with failures in this group. And when we see avascular necrosis has started, we wait for it to burn out before we do anything. And sometimes that's a very long and difficult wait. This is why we've evolved from using headless screws to headed screws. If we looked at the patients that were treated with headed screws, 8 out of 8 united, compared to only 3 out of 8 with headless screws. And if we look at the AVN rate, the AVN rate seems to be lower in headed screws versus headless screws. And why that might be the case, I think what happens is in pediatrics to start with, the radial head has more cartilage than bone. And so headless screws rely on bony purchase, but in cartilage, they don't purchase well. And additionally, once the AVN situation kicks in, then the head becomes even softer, and the headless screw, which has threads in the head, just is not able to provide that compression and stability. And when that part of the head dies, you have sharp cutting threads on the head of the headed screws, which end up potentially doing even more damage to the other side of the joint and to the ulna. So we find that counterintuitively, using headed screws, these patients have actually less metalwear irritation than compared to headless screws. So overall, what are the lessons we've learned from these 20 difficult cases is that early recognition of Solder-Harris 3 and 4 radial head fractures are very important. And this is because they are very different to Solder-Harris 1 and 2 fractures, and they're different to skeletally mature fractures of the same fracture pattern. The natural history is poor. Rapid degenerative changes are likely due to an avascular necrosis phenomenon and inflammatory response. Our results would favor early internal fixation, even when the fracture appears very undisplaced. Headed screws seem to do better than headless screws. Care with periosteum when attempting fixation, and that subluxation of the radiocapitellar joint does not appear to be the primary ligamentous issue, but rather secondary to non-union and AVN. Contracture releases and ligament reconstruction does not work in this group when acute AVN has set in. So this is our latest theory on the pathogenesis of why this condition behaves so poorly. There may be a genetic predisposition, and it doesn't seem to happen to everybody. The terrible ulnohumeral sort of changes doesn't seem to happen to everybody. The radiocapitellar joints are quite predictable. And there's a disruption of blood supply once you have an injury here that damages the transverse epiphyseal vessels, the perichondrial blood supply, as well as the physis being a barrier to revascularization. This then probably leads to avascular necrosis of the radial head, which is the primary driving factor, which manifests as non-union of the fracture, which then leads to joint subluxation and destruction of the radiocapitellar joint. For the ulnohumeral joint to be affected and for the radiocapitellar joint to be destroyed at such a rapid rate within 6 months. There must be more than a mechanical phenomenon, and therefore there must be an inflammatory phenomenon, an osteoclastic phenomenon, and this together with continued load bearing can lead to destruction of the entire joint as part of the natural history of this condition. Thank you.
Thanks, Kemble. That's truly depressing in terms of that injury. It seems for the delayed diagnosis group and a couple of those pictures you showed, they were pretty small. They were pretty small fragments with significant consequence. So there's a question from Andres here. The inflammatory process to burn out before is this the delayed presentation? There's already established synovitis in the joint and subluxation, but you're worried that that process is active, and so you won't fix that fracture. Is that correct?
Yeah, look, I think that the key, so that point, waiting for it to burn out, is mainly addressing the stiffness, which these kids can have really horrendous stiffness with almost an ankylosed joint. And it's very tempting to go in there in that situation with the subluxated radial head, which typically goes back posteriorly, although it can go anteriorly, and a progressively stiff elbow to then, and you're sitting at this now at 6-9 months down the road to say, oh, okay, surely, this is time to do a contracture release. But our experience is that the contracture release and any kind of ligament reconstruction just ends in just no improvement, just ends in tears. Early on, so when I fix these, I think the earlier you fix these, the better the outcome you get. But you can sometimes get a reasonable outcome when you fix this at around about 3 months mark, although the risks are higher. So I would still attempt fixation, but I would give the parents a very sort of poor prognostic outcome and warn them about the likely down the road events. But if we can fix it and get it to unite, I think they do better than if they don't unite and end up undergoing the natural history. But the key is the contracture release just does not work, and the ligament reconstruction, though tempting, just does not work.
Is there any role in that case for if the etiology of that secondary joint destruction, the ulnohumeral joint involvement, is not just mechanical? Should these kids all be commenced on COX-2 inhibitor or similar as a prophylactic measure before that?
That's a really good question. Like a bisphosphonate or something like that. That's a really good question. I've thought about that. I haven't tried it yet, but maybe it is the way to go. I'm aware of, the closest analogy I have for this is the femoral epiphysis, slipped upper femoral epiphysis in children where they can undergo an AVN process. And I'm aware of some previous attempted trials of bisphosphonate in those age group and those patient groups, but I'm not sure whether they had a very positive outcome. Does anyone know of the outcomes of that group? But maybe this is the way to go, given that they all seem to go down a very negative path if left alone.
It seems it certainly seems to be quite a different process to sort of the normal AVN and focal collapse, and then sort of secondary changes kicking in later down the track when there's established deformity. There's one question here from Georgia Antonio. Tendency of the radial head to subluxate is in all positions, or testing in pronation or supination of the forearm is important to identify this. So is the subluxate, if I'm getting this right, the subluxation that we see in your pictures, is that reducible with for different positions of forearm rotation, or is it a global?
Yeah, so I don't think it's
subluxation?
important, the position that the arms are. Like, we all know that in, Montages or other pediatric radial head conditions, pronation tends to lever the radial head out anteriorly, and supination puts it more posteriorly. And we all sort of think about sometimes which position to immobilize the arm in those situations, but it doesn't make a difference in this group. I don't think, because it's kind of like the socket is never able to unite. And look, I think it's an AVN process, because in the hip, for example, you can see AVN because it's a bigger bone. You see those typical changes on the x-rays, but in a little radial head epiphysis, you can't see the actual changes in the epiphysis. And therefore it manifests as non-union. And if you have a non-union of essentially a socket that holds the ball, no matter which position you rotate that socket, it will still eventually end up subluxating in the majority of cases. So those subluxations are generally static. They're not usually reducible by simply positioning. Sometimes when I open them up and try to fix them, I do a little bit of contracture release, and then at the end of that case, I might position it in pronation or supination to put the radial head in a better position. But even then, if it doesn't unite, it will just do its own thing and slide out, usually the back and sometimes the front.
Well, that's a cheery note to kick off this evening's talks. Thanks very much, Kemble. Obviously, the message here there is to recognise it in the first place and deal with it. Or if you can't deal with it yourself, get it to someone who can. So I think we might go to Kristen. Can you share your...
Yep, I'm doing it right now.
Great. Thank you very much.
Can you see? Yeah, can you see my screen?
Yep, we're good. We're good.
Okay, perfect.
So I'll just quickly introduce you, Kristen.
Yeah.
Kristen's plastic surgeon from the Sick Kids Hospital in Toronto, which is obviously a very famous pediatric hospital in Canada and the world. Kristen did a fellowship in St. Louis with Susan McKinnon, if I'm correct. She has a broad experience in pediatrics and in reconstructive microsurgery and peripheral nerve surgery. So it's all coming together with this talk here for us. And this is something I've got a person significantly interested in myself. So I'll be really interested to hear what Kristen's got to say about this.
Yeah, good. Yeah, thank you. I was going to say my disclaimer is I'm a plastic surgeon. I don't treat the supracondylar fractures themselves, but I do follow the nerve injuries. And I've spent the last few years trying to better understand these nerve injuries. And there should be 2 papers coming out soon from this work that you're about to hear about. And really, so in Toronto, at Sick Kids, there's a centralization of the care of these supracondylar fractures, so our community hospitals do not touch them. And so as a result, our orthopedic surgeons treat a very high volume per year. And then there's these nerve injuries as a result. And when I started my practice, I was starting to get referred these, everyone knew I had this real strong interest in pediatric nerve, and I would get these referrals on these nerve injuries after supracondylar fractures, and I really didn't know what to tell the families. Like, when you look at the literature, there's a lot of literature on mitigating nerve injury from the orthopedic perspective, how to avoid iatrogenic nerve injury, what nerves are injured. There's a very good meta-analysis on that. But there's actually relatively little data on how these nerves recover. And the data is a little bit spotty because it comes either from, the orthopedic perspective that references all of these, nerve injuries as neurapraxias and they all recover, to the other extreme where you have these peripheral nerve centers that are seeing really bad nerve injuries and the reconstructive part of that. And then there's also a focus on motor recovery in the literature rather than sensory recovery. So there's a good study from Boston Children's, and it was a very good study, but they only talked about motor recovery. And what I was getting referred is, especially late, okay, their muscles recovered well, but I was getting referred for ongoing sensory complaints. So I was really having a lot of challenges trying to understand, how I should approach these and how the majority should recover. And so my ultimate question is how to predict who needs close monitoring and intervention. So, there are these cases, like this is an obvious case that no one would really question. This was an 8-year-old, left supracondylar, treated with a closed reduction. But at 4 months post-op, I give all radial nerves 4 months to start showing me some wrist extension, and there was absolute zero recovery. And no sensory recovery, really poor sensory recovery as well. So this is obvious that something's gone wrong here. And sure enough, we found that the radial nerves were stuck in bone. And after we extracted that, the intervening portion of the nerve looked like this. So we cut it out and I grafted it, and the child did well. But then I think the majority fall into this not so clear category. So remembering that children are difficult to examine sometimes, particularly when they're young. You can sometimes not get accurate sensory exams. There's, a lot of inconsistency sometimes if the children have issues with motor planning, or this particularly child was running all over the room. It was just really hard to get a consistent exam. So it took a few exams to really try to understand whether we were worried or not. But when I saw him at 6 months, he did have intrinsic recovery, which was interesting, but I was very worried about his early biting of the index and middle finger, which is rare. It's something we see sometimes in total brachial plexus birth injuries, but not something I would typically see in this type of nerve injury. So even though he was getting some sensory recovery over time, I was quite worried about him, and we were having a hard time getting him to reliably flex his FPL and the FDP to the index, and it kept vacillating. So at the end of the day, after some nerve conduction studies that told me that part of the nerve wasn't working well, I took him to the operating room. And again, so here it was interesting that only part of the nerve had been trapped in bone. So the nerve was completely twisted around, and when we finally kind of extracted it, part of it was intact and stimulating well, so like the pronator and all the things that were working preoperatively, but then part of it was in discontinuity, which kind of explained his non-anatomic recovery. So I did an ECRB to AIN transfer, and I grafted him for sensation. So that's just a prelude to kind of how I launched into studying this. And so I conducted, there was 3 studies. So the first study is I was like, okay, great. We have all this historical data. I'm going to try to look at this and figure out how these nerves are recovering. So we did a 10-year study. It was a retrospective study. There were 1,783 patients who had a supracondylar fracture during that period, treated at SickKids. They were all younger than 18, obviously. But what I found is that, so we wanted to look at both predictors of nerve injury as well as predictors of nerve injury severity, but I couldn't, because the documentation of the actual nerve, there was good documentation of whether a nerve injury had occurred, but very poor documentation of how that nerve injury progressed over time. And, at our center, there's fracture clinics that are sometimes run by trainees. And so there was varying levels of expertise that were evaluating these children. There was no sensory assessment at all. It was only motor assessment. There was a very strong focus on the AIN and very poor documentation of intrinsic motor recovery, particularly for the median nerve. And so we weren't able to look at this, but we were able to look at predictors of nerve injury in this study, which I'll just show for interest. So overall, we had 16.5% of these that had a nerve injury. The vast majority were median, and in this retrospective study, there was about 51% of them had an AIN-only injury that was documented, and this kind of reflects what is seen in the literature as well. We had 16 that had multiple nerve injuries, and the vast majority of these were deemed traumatic, with only a small number of iatrogenic. And so here are some of the predictors in the univariable analyses. So older age, vascular injury, open fractures, flexion injuries, and Gartland 3 injuries. And I think it's important to note that in our institution in general, a lot of these fractures are closed. And in some of the series that I've seen, there's a higher rate of vascular injury or open fractures in their studies. So just to note who we're seeing, we don't seem to have a lot of open fracture mechanisms and vascular injuries. Number of pins. So the more number of pins, the higher likelihood of nerve injury, which is probably a surrogate for something else. Open reduction and fasciotomy were all correlated with nerve injury. And then the multivariable model, which we restricted to extension type fractures because there just wasn't enough of flexion type injuries to do a good multivariable model. Really, it was vascular injury and Gartland 3 fractures versus any other type of fracture that had more than a 6 times odds of having a nerve injury. Older age and having more than 2 pins was also predictive, but the odds ratios was much smaller. And as I said, greater than 2 pins is probably a reflection of how, the mechanism of injury, how difficult the fracture is to reduce. So it's probably a reflection of something else rather than just the pins. So given this, and given the fact that I wasn't able to look at nerve injury severity from this retrospective study, after all that work, we actually did launch a QI study through the Plastics Orthopedic collaboration. And so this was done quite rigorously using QI methodology. And basically, we came up with a new platform and pathway for these nerve injuries so that we could better understand their outcomes. So in orthopedics, all patients with a nerve injury at 6 weeks post-fracture got a formal occupational and physical therapy assessment of their motor and sensory recovery in order to standardize that assessment and equalize kind of the learner ability, as well as to get a more formal sensory assessment with Semmes-Weinstein monofilaments. And then they will get a repeat assessment by OT and PT at 3 months post-injury in orthopedics. And anyone who doesn't have a complete or near complete nerve injury recovery at that moment gets referred to me, basically. And so in terms of that standard assessment, we use the Kendall modification of the MRC scale. MRC is not great, but at least it tries to make it better. And then we also documented their trophic changes. And then an important piece of this is templated orthopedic operative notes that really document every single time, no matter what fellow or what surgeon is doing it, some of the preoperative factors, including, for example, what associated nerve injuries were present and what the grading was, what the soft tissue envelope looked like, whether they had associated fractures, and then whether they had a pucker sign. So this really helped us launch the more interesting study, which is our prospective study that we did over 3 years. And this did include some COVID years, so perhaps this reflects some of the mechanisms of injury that we saw during this time. But we accumulated 93 children with nerve injuries out of 1,144 supracondylar fractures during that time period. And we looked at the spectrum of nerve injury severity and predictors of nerve injury severity. So some of the things that I was interested in this prospective study, we were able to look at in a bit more detail: mechanism of injury, although still we didn't have enough numbers to look at specific mechanisms like trampoline injuries or, fall from, moving vehicles like a bicycle or an ATV. Our orthopedic surgeons were really interested in these multidirectionally unstable fractures and whether that was going to be, some sort of predictor of nerve injury or not. The pink but pulseless limb, there was a lot of interest in that, so we were able to look at that as well. And then I was interested in time to get to the operating room. So, the longer these fractures are sitting out, some of them are seen in the community by the time they get to SickKids and then get to the OR. We do not have a perfect system in Canada where we can get them to the OR right away always. So I was interested in that as well. So we tried our best to look at the number of hours. So here's some of the results. So when you actually measure sensation, what we discovered is that of these 93, of these nerve injuries, we actually had no pure anterior interosseous nerve only injuries. All of them had a sensory deficit. And so I do question some of the literature where it was more just focus on the motor recovery and no accurate assessment of sensory that really says that it's the AIN that's injured. I think in our series and in our practice, and this has continued since that study, all of the injuries to the median nerve are sensory and motor. You just have to look for the sensory assessment. And especially for the median and the ulnar nerve injuries, the vast majority of these nerve injuries took longer than 4 months to recover. So again, the technical meaning of a neuropraxic nerve injury is that it's a demyelinating injury, and therefore it should recover within 3 months. We do not have EMGs on all these children. It's technically not feasible at our institution. I think that would have clarified what all of the nerve injuries. So I kind of use 4 months as a surrogate for whether they were neuropraxic or there was something else going on. And certainly for the median and ulnar nerves, the vast majority were not purely neuropraxic injuries. The radial nerves, however, tend to do much better. So the vast majority of the radial nerves recovered within 4 months following injury. And of the 7 patients that took longer, they recovered within 6 months. There was only one child who needed the reconstruction for the nerve entrapment in bone. The ulnar nerve injuries, so of those that the 6 of them that took longer than 4 months to recover, they had all fully and spontaneously recovered within 1 year. The median nerves were more challenging, though. Again, the majority of the 43 patients who took longer than 4 months to recover did achieve full spontaneous recovery within 1 year. And again, it's really that sensory that takes the longest. The motor tends to recover quite quickly, especially the proximal motor functions, but it's the sensory recovery that tends to lag. But there was a small number that did take longer, and there was one at least that achieved incomplete sensory recovery. It was mild, but never had a full recovery of their sensation. But the patient wasn't bothered by it, so we didn't end up intervening. And in this particular cohort, I was pretty conservative. My indications for doing surgery were either 0 recovery or, there was a plateauing of the recovery over time. So really, and I kind of stuck to that during this time period so that we could see how these injuries were recovering spontaneously. So we only had 8 nerve injuries and flexion fractures, of which all were ulnar nerve. So our multivariable analysis was again focused on the extension type fractures, which were far more common. And in all those factors that we looked at, such as time to OR, mechanisms of injury, et cetera, really the only things that came forward in the multivariable analysis was the type of nerve injury. So radial nerves were better than median. If multidirectional instability, interestingly, was more of a protective factor. So again, it was the Gartland type 3 fractures. And if they were multidirectionally unstable, they actually tended to have fewer nerve injuries. So that was an interesting finding. And then age. But it was really only the type of nerve injury that we were able to pick out in this study of 82 patients with extension fractures. So some of our conclusions from this study, I didn't present all the data, but is that the majority of nerve injuries recover spontaneously. And this has been borne out in a couple of other larger studies as well in the literature. The radial nerve injuries do best, which is in direct contrast with some of the study in Boston Children's, for example. But again, they were only looking at motor recovery. And I think when you actually look at sensory recovery of median and ulnar nerve, you realize that it takes a lot longer for them to recover than we were previously thinking. And most of these injuries were not purely neuropraxic. And I don't really think that maybe there's a couple where it's a pure AIN injury, but that we're not picking up or reflecting in this study. But it really hasn't reflected my experience so far over the last 10 years looking at these injuries. And I think that makes sense. It's not only the AIN that's at the back of the nerve. There's the theners, there's this sensory component takes up the lateral half of the nerve, and the sensory takes a hit as well. So on that posterior part of the nerve that is in direct contact with the fracture and that is getting, the pressure, it's the AIN, the theners, and sensation. And so this is why you see relative preservation of the pronator. The FDS tends to not be that affected, and the FCR as well. And I think it also makes more sense as to why you have this mixed pattern is that I don't think these are uniform injuries where the whole nerve is affected equally. Obviously, if it's cut or if it's trapped in bone, yes. But for the majority that are showing spontaneous recovery, it recovers at as a mixed injury does. And I love this graph from Susan McKinnon. It really helps me conceptualize recovery of nerve injuries in general. And this is what you see, and this is reflective of our practice. So in the true demyelinating injuries, you see nothing, nothing, nothing in terms of recovery, and then all of a sudden, everything recovers at once. And we see some of these in the nerve injuries following supracondylar fractures, but I also see, particularly for median and ulnar nerves, more of this mixed pattern where you see early recovery of some of the functions, and then these kind of intermittent bursts as different parts of the nerve that had been affected differently recover. So I still have, a lot of questions actually as it relates to these nerve injuries, and I think we need to do more. I am wondering, I was really surprised that the time to OR wasn't a predictor of nerve injury, and I do wonder if we just need more numbers in order to pick out some of these features. We also didn't measure certain things like the degree of displacement of the fracture, or the direction of the displacement. So we could look in more detail at that. But from what we gathered, vascular injury and Gartland 3 were the strongest predictors of nerve injury. And I do wonder if they're also predictors of nerve injury severity that we just didn't have enough numbers in this prospective study. Some of the things that we're doing now is harnessing dynamic ultrasound to look for early entrapment of the nerves and in fractures. So this is, and potentially use it. So there are certain measures that they can get from these dynamic ultrasounds, such as the enlargement of the nerve. And so I'm curious as to how that may relate to eventual nerve injury severity. I'm also curious, we've had a couple of patients who've had extensive pain, like neuropathic type pain after their fracture. And I'm quite curious as to how that relates. Sometimes I'm thinking, oh, I'm worried that they're going to have more severe injuries, and it doesn't always bear out, and then they end up recovering. So how does that relate? I think that's an important thing to look at. And then I'm also very curious as to, so yes, when the children are not recovering, they need a surgery, but then does early neurolysis, may that hasten nerve recovery in some of these median nerve injuries that really seem to take a long time? Or is it just that they have axonotmetic injuries and they're going to take a long time to recover? So I'm trying to sort that out now. So I don't have all the answers, but I do think we've learned some things, and I feel a lot more confident when recommending an operation and when counseling families. So I hope that was interesting, and thank you very much for listening.
Thank you, Kristen. That's fantastic. The great studies, and I would completely agree with the relative paucity of when you're doing a retrospective review of these patients. And you look through the notes, and there's nerve tick, and that's as granular as the data gets in most of these retrospective looks at it. We looked at a series sort of serendipitously of children referred to our therapists for persistent median nerve deficit. And the group that had been explored had a faster and better sensory and motor recovery than the group who had not been explored. That's a paper that we published. Both Kemble and I were involved, as well as Dan Wilkes. And I think we feel a bit the same. We're a bit more aggressive, I think, about on the basis of that study, we now are more willing to open up and explore these children with persistent deficits. And I think
can I ask how you define persistent? Is it 6 months or longer?
Even acutely, if they're even earlier, on the basis that there'll be a group of children. There'll be some who will have had a nerve injury that's, a neuropathic injury with disruption of fascicles, and it's all very clear at the time acutely. That's a pretty small group, but I think there must be a group of kids who get ischemic injury on top of the traction injury, the closed injury, and the benefit from a decompression without necessarily doing a reconstruction, neuromer excision. I think that's sort of what you're alluding to there, the neurolysis group, whether you accelerate there.
I find the ulnar nerve injuries a little bit easier to pick out when they need a neurolysis, because often there's a discordance between their motor recovery, like they have good intrinsic recovery, but terrible sensory recovery. And we know that the sensory fibers are on the outside of the ulnar nerve near the elbow. So it makes sense. And I find those easier to commit to early. But the median nerves, they're like, sometimes they're surprising. Like I'll get to 6 months and then some of them will all of a sudden have this huge rapid recovery. And I have queried also whether some of them have really a lot of callus formation and have these elbow flexion contractures as well, or they're not able to fully flex. And so I have wondered, because I wonder if it's also like a resolution of the callus and inflammatory process around the nerve, and then all of a sudden I've been wondering about that too, and I don't know how best to measure that, but I've had a couple of kids where it's like, okay, once they re-achieved the ability to fully flex and extend their elbow, it seemed to correlate when they had a rapid improvement in their nerve recovery. And I don't think they all need exploration. I quite firmly believe that, but I do think some of them do. And I have tended to be more aggressive since this study in neuralizing the median nerves around that kind of after 6 months, if they're still really quite behind. But I haven't been as aggressive as you. So I'm not sure what the right answer is. I do benefit. Yeah.
I think, I think we need to stratify the risk, and I think ultrasound will help.
Yes.
But I think and I completely agree about the AIN thing. I think it's a median nerve injury, and it's just a reflection of inadequate assessment.
Yes.
Absolutely. And I think I worry that we explore too often, but then I'm not sure we do a lot of harm by exploring, other than putting a scar on the front of the elbow, which, and there's a bit of a sense of, because that 6 months is a long way to wait, particularly if it's nothing much happening. It's hard to sit on your hands.
It can be, yes. I think the accurate sensory assessment and the accurate assessments actually really help, because you can see the incremental progress. So yes, I'm worrying if they're really slow in those first few months, that's a red flag for me. But if they're kind of making, the expected progress, and often you can actually follow that to Nels. There's often a delay, as you know, right, from the proximal to the recovery. And most of the kids I find, as long as I'm tracking a good progression in the Tenels, I'm happy to wait. But if it's stalling or I'm not certain, it can be tricky. I think we still have a lot to figure out. We've just, scratched the surface, but it would be nice to be able to stratify.
Yeah, I completely agree. So just quickly, there's a couple of questions in the chat. So Kemble, do you want to unmute yourself and ask your question?
Yeah, thank you very much for those fascinating insights, Kristen. I guess just following on from that, whether you have any recommendations on exploration of the nerve at the time of pinning, because since Dave and Dan and we sort of looked into this area, we have, as a unit, orthopaedically at the Royal Children's in Melbourne, almost universally moved to, if the kid comes in with a nerve injury, radial or median, we would perform an open reduction before attempting reduction, if that makes sense. As in, identify the nerve, release it, and then move on to a reduction. And I guess the rationale for that is partly, you make sure the nerve is not entrapped in bone or tethered by soft tissue, but also during the reduction process, that we're not doing the nerve more harm. Because often, once I open up and find the nerve, it's draped across the fracture, and I tell the trainees, okay, now you attempt to try to reduce this and pretend you can't see the nerve. And they're all horrified at what they would actually be doing to the nerve with the nerve draped in front of the bone. the amount of damage that can potentially do in addition to the initial trauma. So
it's interesting. I am aware of this approach, but our orthopedic surgeons are like on the complete. So the two that are most invested, we have a big team and they all manage supracondylar fractures, but Mark Camp and Andrea Chan are most interested in this, and Mark Camp really helped me with this study. But you know, they disagree with that, the acute exploration. So I think our study shows that most of them don't need, like, recover just fine without an acute exploration. So yeah, or a good chunk of them do, especially the radial nerves. Like I would not explore a radial nerve injury based on what we found. They all do very well. There was like one in this series, but I haven't even seen one since that's entrapped in bone. So that's a pretty rare phenomenon. So I don't know that justifies, like I would agree for that. For the median nerves, I am aware of the pros and cons, and they're not for that. Maybe it's because there's so many and they don't want to be opening them all. I don't know. So they have pretty limited indications to open. So their criteria are if it's an open fracture or if they're struggling with the reduction, then they'll open. It's a pretty limited number that get opened acutely. And I think our study shows that you don't have to open all of them acutely. But perhaps there's a cohort that would truly benefit, and maybe it's the median nerves. I mean, the radial nerves off to the side, it makes sense to me that it's more mildly injured than the median nerve. So I think it's really those that we need to pay attention to and really focus on stratifying who needs acute exploration, because it does add a cut. Like, you know, there's risk potentially depending on who's doing. Some orthopedic surgeons are very comfortable with the nerve anatomy, but if you have a fellow who's doing, like at our center, doing some of the reductions, you know, I don't know, I'd feel a bit nervous. So I think we have to stratify and figure out who it is that needs acute exploration. But it's a good point.
That's great. Thanks, Kristen. It's fascinating to hear, because we live in a bubble a bit, and unless we sort of discuss each other's perspectives, we're not really making progress, are we? So it is fascinating. I guess the consequence of missing an injury, it's a pretty devastating problem. The bad injury that is missed, or that's a big consequence. That's a price to pay. But I think we probably need to go back and have another look at what we're doing again. But that's okay.
Yeah, I think I respect all the different views. I think you can make an argument for both. I think the true trapped in bone ones, though, as you said, are pretty rare.
Yeah, no, I think they're rare. I'm more thinking about the soft tissue compression as a sort of secondary injury on top of what's the thing that evolves over the course of the first 4 or 5, 6 weeks. But that is fantastic. Looking forward to seeing those papers come out, and I'm sure we'll talk some more.
Great. Thank you so much.
Thank you very much, Kristen. So the last presentation tonight is Petra Grahn from Helsinki, and Petra is going to tip all of our traditional thoughts about syndactyly release on their head. So Petra, can I ask you to share your screen? And
absolutely.
So Petra's an orthopedic surgeon from Helsinki. It's a special hospital for what have we got? Helsinki New Children's Hospital. And she has an interest in brachial plexus injury, trauma, and congenital difference. So, Petra, really appreciate you joining in tonight and your talk on Syndactyly, beyond the Z-plasty.
Yeah. So hello. I'm just making sure you can hear me, right?
Yes, we got you.
Excellent. So thank you for the nice introduction, and I'm really sorry if I missed a slot here because I miscalculated the time difference. So, but I'm here, and I'm very happy if you have the patience to still hear my talk. So I was asked to talk about our approach to Syndactyly, and I thought to start off just by shortly going through the history a little bit, the history of Syndactyly separation as it connects to the main topic of my talk, which you will see later. So in the early 1800s, web digits were separated with scissors, kind of like here in this picture in the nursery, creating two raw surfaces on the opposing fingers, which were left to heal by secondary epithelialization. This again led to flexion contractures, and a lot of effort was put on developing techniques to avoid this. Cronin and Webster reported that flexion contractures did not develop if web fingers were separated with zigzag incisions in their paper from the mid-1900s. And since then, most surgeons have adopted their technique, and many modifications of it has since been developed, some of which can be seen here in this image. So the main goal in syndactyly separation is to, of course, separate the digits and to create an anatomic and aesthetic web that will last throughout growth. Children are usually operated quite early because patterns of hand function develops around 24 months of age. And there is a consensus that complex cases which impair hand function should therefore be treated relatively early. In incomplete simple syndactylies, we should probably wait a bit longer since both the use of hand creates more skin through stretch and the risk of scar contractures through growth decreases, the less of course, the child has to grow. So what about skin grafts? This here is a basic geometric image indicating that syndactylized digits offer less skin than needed for complete coverage of both the separated digits. And many surgeons that use the graft technique, skin graft technique, cite this image. However, we believe that this mathematical calculation a little bit overestimates the real difference between syndactylized and separated digits, as it does not take into account defatting and the flexibility of the young child's skin. In a clinical situation, the skin is often slightly concave rather than stretched over the two fingers, as you can see here on the image on the right side. And in those cases where this is not the situation, then there is quite amount of excess subcutaneous fat in between the digits. So when you also take the defatting into account, you see that even less skin is needed for direct closure. And this you can see here on the left digit, where this the black color here symbolizes the subcutaneous fat. So if all this is removed from the digit, you can see that direct closure is possible. And in our unit, we have been developing graftless techniques since 2003. The main reason for this is aesthetic problems caused by grafting on both the graft site as well as on the separated fingers, such as hyperpigmentation, hair growth, and excess scarring. Here are some of our early versions of our graftless technique using setplasty. And I think, bearing in mind the previous image, it's very important to remember that a good defatting is very important if you do graftless technique, as a too tight closure is not good, since it raises the risk for infection and scarring, and through that then these secondary complications like flexion contracture and web creep that we want to avoid. So even if you take all these things into account, you might still end up with something that looks like this. These are images of one of our patients, a young man that came for a checkup to our clinic as part of a long-term follow-up that we are doing on syndactyly patients. This contracture developed during his growth spur, which occurred years after our standard follow-up has ended. Usually we have seen our patients maybe 1 or maximum 2 years after separation and then told them to contact us if something happens. Of course, they were giving the same instructions, and teenagers do not necessarily talk to their parents too much, and this this happened. I think it was within a 2-year time span. So the question is, do we really need setplasties in syndactyly separation, as they do also create flexion contractures? It takes experience to get the setplasty design right. I think we all know that. Often we have one finger having too much skin and the other one having too little skin. And the closure of these setplasties is quite time-consuming, especially if you use skin grafts also. So we started to think that maybe a straight incision is not that bad after all. And maybe we should sometimes challenge rules that have been made long before modern surgical instruments and technique were developed, or at least try to then see or prove for ourselves that this is not working. So in hand surgery, we know that the mid-lateral finger incision is okay, and we use it. So why not use a straight incision in syndactyly separation with a mid-lateral closure to separate the digits? So we took our graftless technique a little bit further, and then we came up with something that looks like this. And this is what our approach looks like now. And as you can see, it offers also a small amount of excess skin marked by the asterisk there in the digit on the right lower image. And this can be used to cover areas needing a small graft if you are not comfortable with leaving it to epithelialize. Usually with this technique, these bare areas would be on the lateral aspect of the DIP joints in simple, complete, or complex syndactylies. And of course, when developing something new, you need to have a thorough follow-up and see how your patients are doing. And that is what we are doing. The first patient had finger separation using this technique in 2015. And since 2017, this has been our standard approach, and it is also the technique I currently teach. All patients are part of a prospective follow-up until end of growth. And these are just some of the results of 72 patients that have had a minimum of 1 year follow-up. 4 of these patients have been adults, and 5 additional patients have had toe syndactyly separation. We have separated altogether 105 finger web spaces using the technique. And like said, our mean follow-up at the moment is 5 years. We have used pre-distraction only in 3 patients, 2 upper hands and 1 complex complicated syndactyly. Here are the levels we have separated. The most common level is, of course, simple incomplete syndactyly to the PIP joint, but we have separated 28 simple complete syndactylies and also complex and complex complicated syndactylies using this technique. These are some of the current results as reported by the parents, since the children are still quite young to report their own results. Of course, apart from this, we also look at sensation, scar quality, cold intolerance, and patient-reported satisfaction. We also look for flexion contracture, lateral deviation, and rotational deformities, but so far we have not had any issues with these. Our mean cosmetic visual analog scale score is 87 at the moment, which is really good. And our functional score is even better. It's 90 at the moment. We also look at the web creep using the Whitty web grade, which you can see on the image on the right side. And currently it's at 0.5 with a range of 0 to 2. I have here some patient examples. The first image is showing the best and worst simple complete syndactyly separation, with the left side image showing the best one 5 years post-operatively, full cosmetic and functional scores, and the right side showing the worst simple complete syndactyly separation at 2 years. This patient developed a hypertrophic scar and also then web creep following that. So the cosmetic score is not that high. This patient has since had reconstruction of the web and has not had any further issues with that. Here is another patient with Poland syndrome that had separation, and this is 6 years post-operatively with good cosmetic and functional scores. Here is a patient with constriction band syndrome. Also, this is only 2 years post-operatively. You can see there the preoperative and the post-operative images of both hands. Unfortunately, they're a bit not clear, the images. We had some problems with our image data bank lately, but this is the best I could do. And also one of our upper patients. And also this patient has been already for a 4-year checkup, and she's doing excellent. But I forgot to take pictures of her. We will have that, of course, in our final publication. We will also have all the pictures available for all the patients. And then also to show you that you can also use this in toe syndactyly. This is 2 years post-operatively with very good cosmetic scores. And finally, I have one adult patient that came in for syndactyly separation, an immigrant that had moved from another country, and he wanted to be able to wear his wedding ring on the right finger, and also to wear gloves, which is quite necessary in Finland. So he came in for syndactyly separation, and he was very happy with the result. And as you can see, since he has been using his fingers for many years, he had quite amount of excess skin already in between the fingers. So when we did his separation, we did all the fingers at the same time without any problems. And of course, these are only images, and we have complications, as anybody would expect. We have 4 patients that has developed a post-operative infection. 2 of them developed the infection due to dipping their hands in a toilet bowl. I don't know, it's kind of funny that 2 did the same thing. And the other 2, I don't know for what reason they had an infection. Maybe we closed it too tight, hard to say. Hypertrophic scarring we have also in 4 patients. Of these, 3 have been with black skin, which have a little bit higher rate for hypertrophic scarring. So it's something to bear in mind. Our web creep rate is 1.7, and it's related to patients with either having a hypertrophic scar or a post-operative infection. As you can see, in foot syndactyly, there's a very high risk for post-operative infection. I would like to point out that these are all superficial infections. But we have operated 5 patients, and 2 of them have developed an infection. So this is something we already tell the patients in advance, that there's a high risk that you need to eat some antibiotics after surgery. Then an additional 2 patients report dryness in the web space. And I now have a short video I would like to show you where you can see the separation itself. Let's see just if I get it running. So yeah, that was our technique video. I think the main things here to remember that we want to avoid infection. So a tension-free closure is important. We use running suture to get it as tension-free as possible, and we do quite rigorous defatting, as you could see from the video. But as you could also see, many ask us, like, don't the fingers get too skinny? And no, they don't. They look completely normal at follow-up, so that's nothing you need to worry about. And of course, if needed, you need to use skin graft. Don't close it too tight, because then you just create problems for yourself. And if you want to read more about the technique, we published it in 2020. We have still to publish our 5-year results. That's something that we're going to start working on probably still this year. So I'm happy to answer any questions you have, and I'm sorry that I don't have a camera on. I'm actually on call at the hospital, so I didn't find a room that would allow me to also use a camera.
Thank you, Petra. That's great. It's the simplicity of the technique and the results are fantastic. Kristen, you had some question for Petra. Would you like to unmute?
Sure. Yeah. Hi, Petra. Nice to hear your voice again.
Hi.
I think you answered one of my questions. So first of all, this technique is highly appealing as I think about painfully sewing in all the skin grafts, which I do. And so watching that video, I'm like, wow, I do straight line release in APERT, so I do know, but in a simple syndactyly, it would just like save so much time. So it is appealing. So one of my questions you already answered about the defatting. I was worried that you don't even have any temporary difference, even in kids, in the contour of the finger. At all?
No. I really don't feel I do. It's something you need to try, and then you realize it yourself. I mean, like said, they do have excess. It's related to the syndactyly itself, that they have excess fat in between the fingers.
Yeah. No, I buy that too. I was just surprised by that. And then I guess your line, like where you're aiming, are you aiming to have that closure line right on the mid-axial line?
Yeah. Yes.
Yeah. In the toes as well, because it seemed like one of the scars in the toes you showed was a little bit more dorsal. I wasn't sure if that was intentional or it's just
so we aim for mid-axial also in the toes.
Okay.
But I thought I'll focus more on fingers here in my talk. So in the toes, sometimes we actually do need to use a graft. We still use the same incision, but toes are a bit different than fingers, and it tends to be a little bit less stretch in the skin of the feet.
Yeah, and then my final question is, like, I think on every, the whole reason, aside from contracture of the skin or the web space, is with growth. So you have not yet seen any angular, I guess if you get that incision line correctly in the mid-axial line, you have not seen any angular deformity with growth during adolescence following a straight line closure.
Well, so far, no. And this is, of course, something that we are really, really waiting to see, because as you could see, our patients are still rather young. I mean, we do operate them from 1 to 3 years of age, depending on the severity of the syndactyly. So, they have not reached growth spur, most of them yet. But then again, I think that, as I showed from the patient with the setplasty done, the growth spur can cause this contracture even if you do a setplasty.
Correct. Yeah.
Yeah. So, but this is really something we are looking into, and we will of course publish that. And we of course that would be horrible if they all end up wrong. But I really don't think so. They feel the scars feel really good, and we haven't seen any big problems with them. I mean, we would have discontinued using the technique then.
Yeah. Okay.
Petra, can I just ask, on the video, the extent that you undermine the skin flaps dorsally and palmarward,
Mm-hmm.
you're really are you getting to the midline?
No, I go over the midline.
Over the midline, so you're really recruiting a lot of skin from the whole digit.
Yeah, so I mobilize. Of course, I don't do the defatting all the way to the other side because I want to preserve as much of the dorsal nerves also as possible. But I do mobilize it. So I go on the dorsal side. I go all the way to the lateral. I mean, to the other aspect of both digits.
And the venous network adipose tissue in the web space, that you're taking out the fat, but are you sacrificing any of that venous conduit?
No. So the fat is in 2 layers. So those of us who do a lot of syndactyly separation probably can know that there's the 1 layer of fat that is right under the skin, and then there is the next layer of fat that is in between the skin fat and then the paratenon and all these. So we do leave this under the skin layer and the venous drainage of that. So there is good circulation in the flap. I mean, as you could see from the video, it's not white.
No. And just so in the setting where you've got multiple, you've got adjacent syndactyles, and you still stage the release.
Of course, we stage the release. It's only in this one adult patient where I just wanted to show it just as an example that if you have this sort of situation, and then it's possible to do it also in one stage. But in children, we do stage the release.
And if you've gone all the way over to the contralateral side of the digit when you've released one space, and then you kind of come back and release that adjacent digit, how do you go? Is there enough laxity in the skin to allow you to recruit enough to do one web space and then come back and take it back the other way?
Children heal amazingly well. So we have minimum half a year in between surgeries. And we have not had a problem with any type of contracture or mobilizing the skin or blood flow of the skin or the flaps.
And your post-operative regime, once you're taking the dressing down at a couple of weeks or something like that, do you then apply compression to try and keep that scar flat, or?
Yeah, so we start they see our occupational therapist 1 week from dressing removal, and then our occupational therapist checks if they would need any kind of compression garment. Very rarely they do need one, but if they feel that they need, like they have the type of skin that is prone to develop very strong scarring, then they would get some compression garment.
Okay. And Kristen, can I ask, do you use compression garments? Like we do occasionally, but they're horrendously expensive to get.
Yeah, they are.
To get fitted. And
but
I love using them because I think they give you the best photo scar. I use a skin graft, pretty typical triangular flap design, and I try to get away without using grafts if I can with the dorsal pentagonal flap, but usually I end up chickening out and putting skin grafts in because I worry it's too tight. But maybe I'm not recruiting enough skin. But have you got comment on the post-operative?
Yeah, for us, so we rarely use a compression garment for the same reason. It's just very expensive. It's very labor intensive, and but if they're heavy scar formers within the first few weeks after the grafts are healed, you can tell if they're going to be a hypertrophic scar former, especially in certain ethnicities. And we do a nighttime splint with silicone in between. Yeah. I like that, and that seems to work pretty well. And it's a simpler and less expensive option than the compression sleeve. But it would be nice to be able to use a compression in everybody. But we have too many syndactyles. There's just no way I think we could.
Exactly.
But no, I'm very intrigued by this for sure. Like I've just started to dip my toes into these graftless techniques. I was so trained elsewise, just in terms of never do that. So I've been starting to, and it's very intriguing. Your results are very intriguing. So going to think about it.
So
I mean, I was also trained to use grafts and setplasties. So I encourage all of you to challenge yourselves.
Well, the results of grafted web spaces, they look great in kids. So the skin grafts don't look too bad in kids but when they're mature and they hyperpigment or they get hairy, and it's just they're not, the adults who've had syndactyly releases in the past, the results of the cosmetic results are pretty, they're only just, what I mean? I think it's maybe this is the answer. I'll be fascinated to see what your five-year results are like. That'll be really, really a great paper.
Yeah.
Sorry, Petra, you want to say?
No, nothing. I just, we will for sure publish our results.
But I agree with Kristen. The concept of doing a straight line closure is so appealing compared to sewing in skin. It's like,
No, I can't go back anymore. I lost my, I almost became gray-haired from trying to fit the setplasties right. And I always had too much on one finger and too little on the other finger. And, no matter how much planning I did, it's, so this is just so simple.
It's very attractive. Usually the best ideas are the simple ones, aren't they? I would like to, it's 10:30 or 10:30 here. So I would like to draw it to a close. Please, very grateful. All information, and you're very generous with your time to do that for us. So really appreciate your input. There'll be another PULM meeting in May, the second Sunday in May, starting at 1 p.m. I think, Barcelona time. But we'll advertise that well in advance. Thanks again. The talks will be available on the YouTube channel. Andres, have I said everything that I need to say? Is that it?
Yes, thank you to all all great talks. Yes, you can subscribe to the channel you have in the chat, or searching PULM Talks in YouTube, will find it. And you can see all the last year talks are already uploaded. We have to upload the currently year, that we will do it soon.
Yeah, they're a fantastic resource, so I'd really recommend that. Great quality speakers. So thanks again for everybody who's joined in tonight. I hope you've all found it educational. I know I certainly have. Cheers. Thanks very much.
Thank you. Bye.
Thank you.
Thank you.
Thank you.
Thank you.
Bye-bye.
Good night.
Thank you. Bye.
Recording stopped.